All right, so these are my disclosures, and I'm here to talk about why tumor markers are not recommended as screening tests. So this is a bit of a sensitive issue to most clinicians. There may be believers of using tumor markers as screening tests, and will be otherwise. No, but let's try to have as healthy a discussion as possible. Okay, so these are the objectives for my part of the lecture. At the end of the presentation, we would all be able to review what is an ideal tumor marker, distinguish its classification and uses, summarize the recommendations for ordering these tests, and hopefully appraise why tumor markers should not be used as screening tests. So just a bit of a backgrounder. So the history of tumor markers started 2,000 years ago when evidence written on an Egyptian papyrus was discovered, where a substance was actually identified to differentiate breast cancer from mastitis in patients who were discovered with a lump on their breast. And then in 1846, we know that the first tumor marker in medicine was officially discovered in the form of Benz-Jones protein, used as part of the diagnostics for patients whom we consider to have multiple myeloma. And in 1965, the first tumor antigen was discovered by Dr. Gold and his team, where they isolated a glycoprotein molecule from specimens of human colonic cancer. And this is what we now know as the CEA, or carcinoembryonic antigen. So what are tumor markers? They're basically substances present in or produced by a tumor itself or produced by the host in response to a tumor. It can also be defined as a molecule that is altered quantitatively or qualitatively in precancerous or cancerous conditions, which is of course detected by an assay. So in summary, it's basically a biochemical indicator of the presence of a tumor. Now, when we talk about tumor markers, we talk about its characteristics. And these are the ideal characteristics of what a tumor marker should be. So it should be highly specific. That means it is able to detect only one tumor type. It should be highly sensitive, which means that they should not be detectable in patients without malignancies. It should have a long lead time so that it allows interventions to prevent cancer. The levels should obviously, ideally, correlate with tumor burden. It should have a short half-life. It should be simple and cheap. And the specimens should be easily obtainable. Now, these are the ideal characteristics of what a tumor marker should be. But unfortunately, in reality, an ideal tumor marker does not exist for reasons that we will be discussing later. So I'm just going to show you a rundown of the molecular basis of tumor markers. It can be based from DNA, RNA, or translational proteins. And we have so many classifications of tumor markers, but the most common of which would classify them according to their origin, their structure, and their biological function, such as this table, where it shows to us the division and classification of tumor markers, whether it's an oncofetal antigen, it's a hormone, it's a glycoprotein, or any other metabolite. So what are the different uses of these tumor markers? As mentioned earlier, they may have some benefit in early detection, but this statement we have to qualify later. It's also used for diagnostic confirmation or as part of a diagnostic battery of tests. It can be used to dictate the patient's prognosis. And of course, it's used for the prediction of a therapeutic response in patients whom we are treating for malignancy. And it can also be used for monitoring disease and recurrence. So this table shows us the common clinical uses of tumor markers, where malignancies from adrenal carcinoma to breast cancer down to sarcomas and thyroid have more or less tumor markers that can be correlated with these different malignancies. Its use, however, should be intentionally analyzed before recommending such tests, and there are so many recommendations from the different oncologic communities to help us with that. But zooming in specifically to tumor markers as a screening tool, we know that although this is an extremely appealing use, the concept of screening a large healthy population for occult tumors or for asymptomatic tumors by using a marker solely is not currently possible for the following reasons. First, no test yet is 100% specific, and many tumor markers may be elevated in benign conditions. And what conditions are these? There are just so many, but to mention a few, these are some of the benign conditions associated with rise in the different tumor markers. So if a patient has viral hepatitis, has liver injury, has IBD or pregnancy, it may result in an elevated AFP. Patients who use marijuana and have testicular failure may have elevated beta-HCG, and so on and so forth, which you can review in the slides. Moving forward, these are the different benign conditions that can also be associated with a rise in tumor marker, thus decreasing significantly the specificity of tumor markers. Now, there were attempts to improve the sensitivity and specificity of these tumor markers, and scientists have tried a combination of combining tumor markers with other procedures. For example, the use of CA125 together with a whole abdominal ultrasound in postmenopausal patients are advised by some recommendations to be used in diagnosing ovarian cancer. PSA determination in elderly males with urinary symptoms has evolved from the value of PSA itself to the use of PSA density and PSA velocity. And there are so many studies that would help us decide on how to evaluate these tests. The prevalence of malignancy as a major determinant of using a tumor marker is also very, very important. One particular example is the use of alpha-fetoprotein as a screening tool for primary hepatomas in China, because the incidence of hepatocellular carcinoma in China is just very, very high. The prevalence is high, and AFP may be used as part of the screening tool in that part of the region. So, how about the use of tumor markers as a diagnostic tool? Again, it cannot be used as primary modality for the diagnosis of cancer solely, with some exceptions, which we will discuss in a little while. Because its main utility as a lab test is basically to support the diagnosis or in the follow-up of patients being treated for malignancy. So there's a difference between the use of tumor markers solely to diagnose cancer and to use tumor markers as a support in other diagnostic tests that we do for our patients. There, so tumor markers can be used in conjunction with other diagnostic tests to differentiate between benign and malignant disease. So one example would be the presence of an elevated CA125 in postmenopausal women with an adnexal mass, which is highly suggestive of ovarian malignancy. Now, the operative term is highly suggestive. It is never definitive. So it gives you an idea that ideally we would still want to do a biopsy to get a definitive histopathologic diagnosis. So take note that this statement is not true in premenopausal patients, because CA125 can be elevated in premenopausal patients who have endometriosis and pelvic inflammatory disease. So it's very, very important not just to look at the prevalence of a malignancy in a certain region, but also the patient subgroups that you're using a tumor marker on. So another exception is the use of AFP and beta-HCG in germ cell tumors. We all know that if we review the NCCN guidelines, if we look at the discussion part, in patients whom we suspect to have germ cell tumors and are in visceral crisis who would need to be treated, the presence of an elevated tumor marker in the form of beta-HCG, AFP, or LDH could suffice to commit to a diagnosis of germ cell tumor. So if we go into the specifics, elevated beta-HCG, we all know that it can be highly suggestive of seminoma and elevated AFP for non-seminomatous germ cell tumors. So it's important to remember that in terms of monitoring disease, this is the most common clinical use of serum tumor markers. So we all know that it increases with progressive disease, it decreases with remission, and it does not change significantly with stable disease. The important caveat in using tumor markers in monitoring disease is that we have to make sure first that before any form of treatment, the patients have an elevated tumor marker baseline. Otherwise, if you have a patient with non-PSA secreting prostate cancer, it's of little value to monitor the PSA later and use it to monitor treatment response. So just take note of that. So when we talk about biochemical recurrence, it's important to take note that tumor kinetics is more important than individual values. So we do not, as much as possible, we try to see the trend of the differences in tumor markers, whether it becomes elevated or decreased, because it's important to see the time progression, how it progresses over time, more than the individual values that patients show us during their first consult. So a rising tumor marker level may detect recurrence of disease before clinical or radiological evidence. If you remember, when part of monitoring patients with colorectal cancers is through monitoring of CEA almost every 3 months when they follow up with us post-treatment. So if we see a trend in the rise of CEA, then that gives us an idea to investigate further because it may be an early signal of tumor recurrence. So it's important to remember that although an aggressive investigative approach may be warranted on the basis of raised tumor marker values, treatment cannot be initiated without undisputable documentation of the disease. And this is most of the time a definitive histopathological diagnosis. Again, the exception is the use of tumor markers in patients with germ cell tumors. So as I've mentioned earlier, a single value or test is unreliable in itself. We need to do serial testing because tumor kinetics, as I've mentioned, is more important than the individual values. So again, it's important to be certain that the marker in question was elevated before relying on it for monitoring disease activity. So again, as a general guide, the time interval between serial determination should be 3 months. I think this is generally accepted by majority of the oncology communities around the world. But if it is abnormal, then the recommendation would be to repeat it within 2 to 4 weeks, just to see the trend and to confirm that it was not lab error or clerical error. It's important also to take note that patient characteristics affect the tumor marker values to a significant degree. For example, CEA is often elevated in patients with liver disease, and it's also important to check the biology of tumor markers because some tumor markers may not fall below normal values in patients with chronic kidney disease and with liver failure. So these are the different factors that may influence interpretation of tumor markers: lifestyle, smoking, cannabis use, the use of 5-alpha reductase inhibitors in our patients with prostate cancer. Catheterization can elevate the patient's PSA, and even the use of cystoscopy and even DRE could also elevate a patient's PSA level. Now, shifting gears, I'd like to introduce to you the concept of ectopic tumor markers, which can be a source of diagnostic dilemma. So this is actually, when you say ectopic, it's a tumor marker that's elevated differently from the primary malignancy. So this is often due to the autonomic expression of different genes in advanced malignancies, and this signals a poor prognosis among patients. And these are some of the examples of ectopic tumor markers that we may find in our patients. So elevated AFP could be associated with GI malignancies, renal, breast, bladder, and ovarian carcinoma. So the presence of ectopic tumor markers is also one proof why we never base our diagnosis on tumor markers alone. It should be in consonance or in relation to the other diagnostic tests. So just remember the concept of ectopic tumor markers. So now let me go answer the main question of this talk. Are tumor markers helpful for diagnosis in patients with non-specific symptoms? So again, the answer is no, because there's low diagnostic sensitivity and specificity, and measurement is not recommended in patients with non-specific symptoms before imaging or a definitive diagnosis of malignancy by biopsy. And one study that would support this statement is a study done by Dr. Wanabo, where he checked the preoperative CEA levels of patients with colorectal cancer. And you see that patients with Duke A classification, which means that the tumor was just in the mucosa or submucosa, only 3% of them had an abnormally high CEA of more than 5 micrograms per liter. Whereas when the tumor depth invaded already the serosa, which makes them Duke's B classification, a significant increase in the number of patients had elevated CEA. So thus, we cannot really use CEA levels in preoperatively as a screening tool without other diagnostic tests, because just imagine the patients that we will miss diagnosing if we rely solely on CEA. So the next question, so this was for patients with non-specific symptoms. How about for patients who do not have symptoms at all? And again, the answer would still be no, because same reason, low diagnostic sensitivity and specificity. I'd just like to present to you the biggest clinical trials for prostate cancer. It's basically just two. The PLCO trial done in the USA and the ERSPC, or the European study for screening of prostate cancer, which was done in Europe. And these two big studies show two conflicting results, because PLCO concluded that there was no reduction in prostate cancer mortality, while the European study showed a 20% reduction in mortality. If you read the studies, the two different studies in depth, you would see the different reasons explained by researchers why this was the results. But if you talk about hard endpoints, then we always go to the intention to treat analysis data, and this just shows that the data we have now is still conflicting. So how about if we combine different tumor markers, and not just one, but we get all tumor markers for patients without symptoms, and see which one we could use. There's actually one study done in China involving patients who were asymptomatic, and they were screened for cancer by using a lot of tumor markers. So this was actually a very expensive study. And you see here they screened more than 20,000 individuals by AFP, CA, CA19-9, CIFRA 2111, SCC. PSA was measured in men, and in women, they actually got CA15-3 and CA125. And the conclusion was that cancer screening based solely on the application of multiple tumor markers was unfavorable, because the positive predictive value and the absolute risk reduction was just inadequate. So this is so far one of the biggest studies combining different tumor markers for the asymptomatic population, and the results were negative. No? So that means that we cannot really use tumor markers solely to screen patients who are asymptomatic, or even those who have non-specific symptoms. And so to conclude, I think this is the best statement to summarize the use of tumor markers in approaching patients with malignancies or whom we suspect with malignancies, is that we should never lose sight of the forest for leaves of a tree. So tumor markers need to be judiciously used, and a thorough understanding of the basics of pathophysiology, the techniques of testing, and the knowledge of their role in a given malignancy is very, very important before we use them for our patients. And with that, I'd like to thank you, Aokun Charawon. I hope I pronounced that correctly. Thank you very much. And I'm very happy to answer your questions if you have any. So thank you.